Welcome to Health Professional Radio. I'm your host, Neil Howard. We're going to have a conversation with Dr. Richard Masri. He's a rheumatologist, and he's joining us here to talk about some new data that was released by Horizon Therapeutics at the annual European Congress of Rheumatology, or EULAR 2020, that shows the benefit of combining immunomodulators with KRYSTEXXA. Welcome to Health Professional Radio, Dr. Masri.
Thank you for having me.
You're a rheumatologist. Give us a bit of your background and tell us where it is that you're practicing.
Yeah, so I did my medical school training in Lebanon at the American University of Beirut, and then I had my internal medicine residency at the University of Kansas in Wichita, followed by my fellowship at Johns Hopkins in Baltimore. And I currently practice in Richmond, Virginia, part of the Bon Secours Mercy Health Center in Richmond, Virginia.
This new data that was released by Horizon Therapeutics, how are you involved with Horizon Therapeutics?
Yeah, so I speak on their bureau. I'm one of their thought leaders, reaching out to physicians in my community, from nephrologists, podiatrists, and to fellow rheumatologists, describing the data what Horizon has produced regarding KRYSTEXXA itself. But out of my own interest of the medication, I decided to undergo a study of patients of mine using their immunomodulator, as you mentioned, called leflunomide, which is a medication that's used and FDA approved for rheumatoid arthritis, in combination with KRYSTEXXA in patients that have uncontrolled gout and those that especially have chronic kidney disease. So Horizon has had some publications from other physicians, colleagues of mine, and within their own company of using another immunomodulator called methotrexate. And there are other data out there for the use of azathioprine and CellCept and cyclosporin. But more interestingly, with methotrexate, which is a great medication, once again, used in rheumatoid arthritis, there are some limitations in its use in patients that have chronic kidney disease, generally moderate to severe. So that's why I decided to use leflunomide, where it's safe in those patients, and there really is no drug monitoring needed with those patients. So I compiled the patients initially and started them on therapy with about a 4-week lead time before the first infusion of KRYSTEXXA at 8 milligrams every 2 weeks. And from this case series I have, about 7 out of 10 patients achieved a complete response, which is described as at least 12 infusions with a uric acid less than 6 milligrams per deciliter. And some of these patients have been ongoing treatments currently. And compared to the pivotal trial what Horizon published regarding KRYSTEXXA without any immunomodulation, their response rate was 42%. So my data showed improvements in the immunomodulatory success combined with KRYSTEXXA to 70%, and my colleagues have data suggesting 80 to 100% using methotrexate as well. So it's very promising. It's a very exciting field right now, what we're experiencing, because this is a fantastic drug for patients that really need to be treated. And fortunately, with the use of immunomodulators such as leflunomide and methotrexate, these patients are going to have a better response to therapy using KRYSTEXXA.
Now, when you say uncontrolled gout, are we talking about gout that has been ignored, undertreated, or unresponsive to other treatments?
That's a great question. I would say that it really encompasses all three. For one, I think gout is a poorly understood condition. Most people think that it's a flare disease and you should just treat it as a flare, whereby it's actually a chronic systemic disease. So just like blood hypertension or diabetes, these diseases need to have, chronic medications to treat the pathology. And this is the same with gout, which once again, I think is poorly recognized, that if you do not relieve the body from the uric acid burden, these patients are going to have complications of their gout. And there is data out there that suggests that uric acid buildup can induce chronic kidney disease and vice versa, where people that have chronic kidney disease from other diseases like hypertension or diabetes can actually cause gout. So it's like a chicken or the egg phenomenon. So definitely it is a chronic disease, it's a chronic systemic disease, and it's not a flare disease. So that's one thing that's poorly understood, is that it's not recognized mostly by our community physicians. Second of all, I think the treatments we have are very good. Our oral agents are traditionally very well tolerated, and patients do well on them. But there is also a limitation, and some patients do not have sustained benefits despite being on optimal doses. And that was a study. There was a study that showed this using allopurinol 300 milligrams and using febuxostat, or previously known as EULAR, 80 milligrams. After 1 year, patients still had flares. So uncontrolled gout can be in patients that are refractory to therapy and continue having flares of their gout, which is a very disabling disease. But once treated well, they tend to have a normal quality of life.
Talk about the importance of clinicians having flexibility when co-prescribing for gout.
So are you asking regarding immunomodulation therapy or just
immunomodulators, immunomodulators and KRYSTEXXA?
Yeah. So that's once again, I think it's a great thing we have, because this is option. We have options in medicine. We don't always have options, and I think with this, the data that we have been releasing is proving that the clinicians have options, different options to use different medications, such as in my case, leflunomide, and then methotrexate. And in patients that have who need to be on Cellcept or azathioprine, those, it depends on what the patient has. If they have bad kidney function, I would strongly recommend leflunomide, because azathioprine and methotrexate may need to be used on a lot lower doses. Cellcept is another medication that's used, but is a twice-a-day regimen, so it increases the pill burden. Methotrexate is a once-a-week medication supplemented with a daily vitamin, and leflunomide is a once-a-day medication by itself. So it really comes down to what the patient is presenting with regarding their own chronic diseases or comorbidities, and what the clinician who's prescribing feels comfortable using. But once again, lots of options, and the data that I have produced shows that leflunomide is as effective possibly compared to methotrexate, although there's no head-to-head comparison. But this, from the data we're seeing, that patients do well in combination therapy.
Not having gout or understanding how it affects a person, on a personal level. What about the severity of a person's condition? Are there different levels of gout that react differently to this co-combination?
So definitely it's a spectrum disease where people can have simple one joint that's involved, and that's the current joint that flares, and there another side of the spectrum where patients have multiple joints that flare simultaneously and have a huge burden of tophi, or collections of uric acid, that are seen visibly under the skin and actually cause damage to the joints and cause loss of mobility, can cause infections, which may lead to amputation. So there's definitely a spectrum disorder. And when using KRYSTEXXA in combination with immunomodulator medications like leflunomide or methotrexate, the patients will feel very quick response regarding their gout. They will feel, in some instances, that whatever discomfort they had in their hands, whatever tightness or stiffness that they had in their hands due to the burden of gout in their hands, they will feel after the first dose improvement in their stiffness, improvement of their rigidity in their fingers as a consequence. It's very rapid response, and they will see the tophi abate or resolve or melt away. They will physically see those lesions going away with each infusion. So you're actually seeing something and feeling something with every single dose, which is quite amazing in my opinion.
Well, where can our listeners get some more information about KRYSTEXXA, about this research, and maybe more about your background as well? So
Horizon definitely has their own website with their links for KRYSTEXXA itself, and they also have inclusions of their study with methotrexate. But the ACR and the EULAR websites, which are representative of the rheumatology community internationally, also have information about these studies and these poster abstracts and even publications. So there's lots of ways of getting access to this information. And of course, a simple Google search of my name will pull up my information, and hopefully will pull up the abstract that we published.
And that EULAR website is eular.org, eular.org, EULAR.org. Well, I thank you for joining us here on Health Professional Radio, Dr. Masri.
Thank you so much for having me.
You've been listening to Health Professional Radio. I'm your host, Neil Howard. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au.